Good evening, everybody. Welcome to the BASH webinar number 3 of the 2021 series of BASH webinars. My name is Fayaz Ahmed, and I am a neurologist in the northeast of England in the Yorkshire region, and also the educational officer for the British Association for the Study of Headache. These webinars do occur on the last Wednesday of every month, and this is the third in the series. I'm very grateful to British Association for the Study of Headache, our chair, Mark Wetherell, our administrator, Paul Aswood, in assisting, and our industry partners, Allergan, Teva, Lilly, and Lundbeck, who kindly give us the educational grant for us to keep running these webinars. The webinars are obviously approved for 2 CME points for each webinar. So if you're attending all of them, you'll get 24 external CME credits. And I've given the code. That's probably the one which you need to mention because we are not issuing certificates. The webinars are also available on iClouds the day after the webinar, and I send you the link. And about a month after the webinar, it all goes into the BASH Education UK YouTube channel, and you can watch there whenever you like. All things are available. So we started in January with history taking and went on to the secondary headaches in the second month. And the next one we have is the migraine pathophysiology, which you will be listening today or watching Phil and Farooq and Anna, the 3 excellent speakers we have. The next webinar, just to introduce it, if you register yourself when I send you the link, is the acute and preventive treatment options of migraine. And we would have next month, Callum Duncan, Brendan Davies, and Louise Rusk. So let's get back to the migraine pathophysiology from bench to clinical practice. We have Phil Holland, who would be talking about the current understanding in migraine pathophysiology. This would be followed by Anna Andreou, who would talk about what are the future aspects of the migraine research and the novel therapeutics targets that we might work on in the future. And this would be followed by Farooq Maniyar talking about the clinical perspective, mainly talking about the functional imaging. So without taking any further time, I would introduce my first speaker, Phil Holland. Phil Holland is a senior lecturer in neurosciences in King's College London and has done and published a lot of work on migraine pathophysiology. So Phil, the dice is yours.
Great, thank you, Fayaz, and thank you to BASH for inviting me to give this talk just as an ice cream van pulls past the house. So if you all hear that tune. Just wanted to come online and say hello. I'm going to turn my camera off during the talk, but just come online and say hello to everyone so you can all recognise me. And you maybe have seen me at a number of BASH events over the years up in Hull with Fayaz, these great events they host. And hopefully we can get back to doing that in person at some time in the future. But for now, we'll provide these online education supports and hopefully you find them useful. So I'll start the talk now. Hopefully everyone can see that, okay?
Yeah, that looks fine, thanks.
Great. So I was asked today to speak about the migraine pathophysiology from bench to clinical practice, and it really mirrors what we do in my laboratory. We're interested in translational neuroscience, so translating what we can find at the bench to the clinic, but also translating what you see in the clinic back to the bench so that we can try and understand the mechanisms that underlie these patient phenotypes that you see, and perhaps discover new aspects of the biology that we can either augment through lifestyle interventions or treat through novel therapeutic approaches. And that's really what I'm going to be talking about today now, migraine less about headache and the actual attack, but more about migraine and disorder. And with that in mind, change slides here. There we are. When you see your patients, and we understand migraine as a headache disorder, but we also have to remember that it's a multisensory disorder. It's a disorder that affects photophobia, so the integration of light, osmophobia, the integration of smell, phonophobia, the integration of sound, and of course, touch, this tactile allodynia, this non-noxious stimuli appearing noxious. And we understand that these senses are processed through different neural networks into the brain, but then they sort of converge on this higher order brain structures. And these higher order brain structures now that are abnormally functioning in patients. And what I'm going to talk about today is some work we and others have been doing around some of these different structures that explains some of these disruption in these networks that lead to patient susceptibility to having an attack. So why, for example, one patient might have 4 attacks per month and another patient might have 8 attacks per month, and how that varies over the cycle. I'm going to show a couple of neuroimaging approaches, but not many, because I know Farooq will touch on that later, so we'll leave that for Farooq. I'm just going to get my laser pointer on here now, in case you want to show. So I'm going to focus mainly on some of the basic science, but we'll touch on some of the neuroimaging correlates of that, so that you can understand the relevance to the clinical condition. And when we talk about migraine being a multisensory disorder, it's not just, as I mentioned, the sensory processing of headache. This is thermal stimulation on patients. And on the x-axis here, you can see hours until the next headache. And you can see that there's a correlation between the time until the next headache and the sensory processing. And it's not just for thermal. Here on the right is visual stimuli. The controls here on the left, migraine with aura patients here and migraine without aura patients here. And you can see at different intensities. So this is the intensity of the...
Phil, I'm sorry to disturb you. There is a problem with your mic. If you could just check, because I think sometimes your sound does disappear a bit.
Okay, well, give me 1 second. What I'll do is I'll put on my headset with the inbuilt microphone. That makes sense. Okay, how's that? Can you hear me okay, Fires?
Yeah.
Right. I've gone to a headset with a microphone set, so hopefully that will stay consistent. So just to recap, what we're showing here is that for different sensory modalities, so thermal on the left and visual on the right, what you can see is that migraine patients abnormally process these sensory stimuli. And this is not just during a headache attack, this is in between attacks in the interictal phase. So we know that there's this brain condition or this brain network state that's leading to this missensory processing of information. And that's really what we've been interested in the lab now for some time, trying to understand how we can get to the mechanism of attack initiation and attack susceptibility within these individuals of migraine. So when we think of that disorder of sensory integration and we think about migraine pathophysiology, many of you will understand, of course, this peripheral arm of the trigeminal nerve here in black, conveying sensory information from the head and the meninges and the neurovasculature surrounding the brain. And that information, of course, synapses in the trigeminal cervical complex within the spinal cord, where it's then passed on to these ascending pain processing pathways, leading up through the brainstem. And we'll talk today a little bit about the periaqueductal grey and the locus coeruleus, some examples here, and the hypothalamus. And primary target being to the thalamus for sensory integration, where it's then processed and then passed on to the cortex for that component. So we understand now this pathophysiology very well of how the pain processing is processed through migraine. What we've been trying to get our handle on recently now is what's happening in these CNS structures that leads to the misprocessing of that incoming sensory information. And as I mentioned, the number of these structures, so the thalamus here, the hypothalamus here, and the periaqueductal grey, we know that these structures are abnormally functioning in patients both before during, and in some cases after the headache phase has resolved in these patients. So this is clearly a network problem that's a part of the migraine condition rather than the headache component of the migraine. It's something we're very interested in. But it's not only ascending information. Of course, we have our own endogenous pain modulatory circuits, and this is a way to dampen down or facilitate pain transmission, depending upon the state in which your body's in. So, for example, we know the classic stories of many injured people who can, run a vast distance to escape from danger, despite having, severe wounds. And that's this endogenous pain modulation that allows you to overcome, or a coping strategy. And that originates in the cortex, down through the hypothalamus, and then sends both direct and indirect projections down to the spinal cord, where it can gate that incoming sensory information, in this case from the trigeminal ganglion. And again, key areas here, so the periaqueductal gray and the hypothalamus, we know are abnormal or abnormally functioning in patients with migraine and other headache conditions. So really pointing to a fact that this descending modulation may be abnormally processed in migraineurs and can lead to a pro-headache phase or a pro-nociceptive phase. And what we see in terms of migraine, this is here on the left, this is looking at migraine frequency now here on the left. And what you can see is that you'll see this as a patient diary, perhaps, where the patient has a number of, one month they might have 6 attacks, another month they might have 10 attacks, and this will vary over the time. And we see this circannual periodicity, so where the attacks vary over time. And what we've been trying to understand is what causes this cyclic variation in attacks. And it's a really important question, because if we can harness those tools to go to the lowest frequency or the lowest susceptibility, of course, we can reduce a significant number of attacks. And it's perhaps most prominent in cluster headache. This is excellent work done by our Danish colleagues. And what you can see is this is cluster headache, attack onset or worsening. And you can see this inverse correlation here with daylight. This is length of daylight hours in red. And you can see this nice attacks seem to dampen down during the peak daylight hours and then rise again during the darker months. So we see this clear interplay of altering attack frequency around certain times of the year. But this also happens within a day. If we think of circadian variation in these patients, this work here on the left is a little bit older now, but showing this clear circadian onset of headaches. So this is migraine attack onset, and you can see that this happens in the early morning through to about noon, and then gradually starts to decline. So there's something about the biology of this arousal component that's leading these people to have more migraine attacks. And some excellent work just a couple of years ago now by our Dutch colleagues, showing that your individual chronotype. So you've all heard now about personalized medicine and things, and thinking about the patient as an individual and treating that patient. Well, then patient's actual chronotype. So whether they're a morning person, likes to get up nice and early and it's really bright and breezy, or whether they're a night owl, as we call it in the UK, where they like to sleep in and are much more functioning later in the day, that can actually predict when they have their migraine attacks. So you can start to think about that now in terms of potential treatment strategies and lifestyle factors that might influence when these people are more likely to have their attacks. And of course, this whole system is controlled by the suprachiasmatic nucleus, this master clock within the hypothalamus, which is entrained by our daily exposure to light. And that suprachiasmatic nucleus, to cut a very long story short, really controls neuronal signaling within the brain. So the level of excitatory transmission, in this case glutamate, the level of inhibition in the form of GABA signaling, and of course other neuropeptides like PACAP here involved in headache and cluster headache, and CGRP itself involved in the pathophysiology of migraine and other headache conditions. So the system can really drive this neuronal excitability or inhibition, and also controls key aspects of the sympathetic and parasympathetic nervous systems that are involved in the pathophysiology of headache disorders as well. And I'll come back to in a couple of slides this orexin here. I suspect Fayez will mention this as well. Farooq will mention this as well. But looking at this orexin peptide and how it might be involved in this regulation of trigeminal pain processing. So this is what we've been doing for a while now. This is where we go to the bench to try and understand this. And this evolved from an original study by Casey Brennan that I'll come on to. And Louis Potacek in San Francisco made this transgenic mouse. So this is a mouse now with the human mutation knocked into it. And this is a human mutation that results in a phenotype called familial advanced sleep phase. So it's a loss of function of this casein kinase 1 delta here, this kinase that phosphorylates period, one of your clock genes. And this, of course, is the clock that allows this 24-hour cyclic behavior. And this disrupts this, it causes an advance of the phenotype, and these patients have this advanced sleep phase. And when you look at these patient families, this is 2 of the families in the original paper, and what you can see is that the black on the bottom here being either aura or migraine on the pedigree, and what you can see is that there's about an 80 to 90% penetrance of migraine with aura in these families. So there's something about having this circadian mutation that impacts the migraine propensity in these individuals. And instead of being 14% of the general population, we're now seeing 80 to 90% penetrance of migraine with aura. So this is what we've been interested in, trying to understand what might be pushing that and how can that help us understand the biology of migraine generally. So original work done by Casey Brennan and his colleagues in these mice. Of course, these patients had a high instance of migraine aura, and the experimental correlate of that is a thing called cortical spreading depression, this spreading depression across the cortex that causes these hemodynamic and electrical changes that the patients often see as visual or motor disturbances, sensory disturbances. And what they were able to show is the black line here being the transgenic animals, is that these animals were much more likely to trigger into a spreading depression event than their wild-type counterparts. So simply by having this circadian mutation that alters your circadian phenotype, you're much more likely to experience the preclinical correlate of migraine aura in these mice. So that was a really interesting point that showed us that there might be some link mechanistically between migraine, this familial advanced sleep phase phenotype, and the biology that we study in the laboratory. And many of you will be aware of this human experimental model. So this is the model of triggering headaches and triggering migraines using glycerol trinisate or nitroglycerin. And what we see is that if you give these patients placebo, you see no response. But if you give these patients the trigger, GTN, what you can see is this sort of acute headache, some people call it, or a throbbing, and then that sort of diminishes. And in a control patient who doesn't have a history of migraine, that will often go back to baseline and you'll get no more response. However, in these patients with migraine, what you see is this delayed onset of a migraine-like attack that they can not distinguish from their normal migraine phenotype. So we get this experimental triggering of migraine. And in this study, they used that same principle to use NTG, again, GTN, just slightly called a different name, but in the preclinical model here with the mice. In grey, you can see the wild-type animal here. And when this animal is given a low dose of nitroglycerin, you can see absolutely no response in that animal. However, the animals with this genetic mutation that's predisposing these patients to migraine with aura, you can see that they have this huge hypersensitivity. So developing allodynia in response to this nitroglycerin. So really showing mechanistically that altering the circadian biology and how the hypothalamus regulates these circuits can have a profound influence on the likelihood of having a migraine attack. So taking that back to the clinic, really what we've got to think about then is this chronotherapy. And that's chronotherapy both in terms of when you might want to treat your patients, but also looking at patients' lifestyles. So are they shift workers, for example? There's evidence that shift workers are much more likely to progress into chronic migraine from episodic. And if you take them off that night shift or shift pattern, altering shift pattern, you can actually switch them back to an episodic migraine condition. So clearly showing that by manipulating this biology of this timing pathway within the brain, we can actually have beneficial effects on the patients. So next time you're speaking to your patients, maybe you want to ask, is there something in their lifestyle? Are they sleeping properly? What's their sleep hygiene like? Watch that headache diary and see if it's progressing and see if they've had a recent change in shift pattern, especially as we come hopefully towards the end of lockdown now and people start to return to work. It's been very interesting that actually during lockdown, most of the studies have shown a reduction in the frequency of headaches. And it may well be that simply being able to entrain to one's own circadian biology or one's own chronotype has reduced that pressure that comes from the working the abnormal hours that many of us do. So
Having introduced the hypothalamus, what we've become interested in, and we've been interested for a number of years, is this neuropeptide family within the hypothalamus called the orexins. There are two of these, an orexin A and orexin B, and that's important for a reason which will become clear. And these are only made in the hypothalamus, but they're processed and sent round the body, round the brain, to carry out a multitude of functions. And the reason we've become interested in them in the lab is because they have a known role in nociception, so pain processing, stress and anxiety, feeding, and wakefulness, and also some role in reward and motivation, all of which have important parts to play in migraine pathophysiology. So we've been interested in this pathway for some time. And in our initial studies, this was work done by Torsten Bartsch, nearly 20 years ago now, 18 years ago now. And he was interested in looking at whether these orexins could modulate trigeminal nociceptive processing. So in this model, we activate this trigeminal pathway, and we can record the number of, or the level of the information that's been conveyed through the central arm of the ascending trigeminal pathway. And what Torsten showed was that actually, if you give orexin A, pardon me, so this is the one here in black, you can actually be anti-nociceptive. So by manipulating this hypothalamic circuit with orexin A, you can actually dampen down this trigeminal response to activation of the trigeminal vascular system. However, if you give orexin B, here the white circles, you can actually facilitate this response. So by simply manipulating this network, and remember this is a network that changes with your arousal state, that changes based on the fact whether you have eaten or not eaten, you can actually tip these animals into a pro or anti trigeminal nociceptive state. And taking that to the patient, then you could imagine that depending on the state the patient's in, whether they have eaten, whether they've had a sleep disruption a couple of nights before, they might be either in a pro or anti headache phase where they're more likely or less likely to trigger into an attack. So it's a really important piece of biology for attack triggering that way. So just showing that if we perturbate these systems, we can impact trigeminal nociceptive processing. And this was some work a PhD student in our group, Margarita Martins Oliveira, did. And she was interested in this from a diet perspective. So thinking about this hypothalamic circuitry that can regulate migraine, and we know all the causal links between skipping meals and migraine and fasting and different things in our patients that you see. And she was interested to understand what's the role of some of these peptides, leptin here, for example, or signaling molecules, insulin and glucagon, that are involved in this feeding and appetite regulation. So she used the same model that Torsten Bartsch had used, where again she was activating this peripheral trigeminal pathway and recording the central processing, so the amount of level of signal that's getting passed into the CNS. And what she was able to show here was, for example, by using insulin and glucagon just to change blood glucose levels, of course, here, but she could also see this alteration in trigeminal pain processing. Here's in the top is the control animals not changing over the 1 hour window. And you can see in the animals given both insulin or glucagon, you can see this dampening of trigeminal nociceptive processing. And she saw a similar thing for leptin. This is a dose response curve. You can see there seems to be a specific dose here at 1 milligram per kilogram, where by changing the leptin signaling within the brain, she was able to augment this migraine processing in terms of the trigeminal pain processing. So here we have another homeostatic network that can regulate trigeminal pain processing based on appetite, for example, and how that would be affected. So this is really of interest to us of how these different brain networks might come together to actually set the threshold for attack triggering within an individual. And just to show that this is not exclusively linked to the hypothalamus, we were interested now in the Locus Coeruleus in this study that we published just a couple of years ago now. So this is a noradrenergic structure, and these in red here is noradrenaline within that structure. And we can take advantage of a known toxin, this DSP4, and that allows us to ablate many of these noradrenergic cells within the Locus Coeruleus. You can see the reduction here between the control animals and the treated animals. And what we see, quite interestingly, when we ablate this structure, is we see, again, a change in trigeminal pain processing, this time an inhibition. So we had this inhibition of trigeminal pain processing, suggesting an anti-nociceptive mechanism on the spinal cord. However, in these same animals treated in this same way, we also saw an increased propensity to spreading depression. So they were much more likely to trigger into this preclinical correlate of migraine aura. So you can see by changing these networks, you have very diverse and important functions on migraine and trigeminal pain processing. And this is really what we're trying to understand within the bench work that we're doing at the moment, is how we can use these networks to try and reduce the number of attacks or the migraine frequency, much like you would consider a preventive therapy in your patients. There are novel ways that we can harness the tools within these networks to do that. So really, that's what we're interested in here. We're interested in trying to understand this role of migraine as a disorder of sensory integration. And we've spoke about here, this hypothalamus has been a very key hub, and I'm very sure that Farooq will discuss this later clinically, so you'll get a lot of detail on this, but also these key brainstem, periaqueductal grey, the RVM I didn't talk about, but again, some great detail on it, and the locus coeruleus, which will be in about here. And we have this network that can tip the animals into this pro or anti-nociceptive state based on the incoming sensory information within this trigeminal branch here. And what that looks like when we really get down to the cellular level, not to really confuse the story, but just to give you that clear, is that we have this on and off component here. So we have this ability via these descending networks. This one's coming from the periaqueductal grey here. We're looking at this brainstem pathway here. And we have this pathway that allows us to both ramp up, so we can turn on and cause facilitation of this pain information, or we can turn down this pain information that's coming in from the periphery, or this sensory information from the periphery. And the important thing about these networks is they're controlled by these very same circuits, the hypothalamus, for example, here, that regulate arousal, that regulate fatigue. So for example, before patients have attack and you see that abnormal fatigue in your patients, we're now starting to understand that this key hub here, this hypothalamus, might play a very important role in setting that threshold for the attack initiating based on a lot of these premonitory symptoms that you might see in your patient. And hopefully in time, we'll be able to develop lifestyle interventions and treatments, as I mentioned, that can actually harness the power of these networks to actually act themselves as preventives for migraine attacks and reduce the frequency. Thank you very much for listening. Hopefully the sound problems went away. Just to say thank you now to everyone who has supported this work, including BASH. I had a wonderful 4 years on the BASH Council, so it's a great time and a great organisation, and also to the Medical Research Council and the Migraine Trust, the Wellcome Trust, and other funders who have really supported our work over the last few years. So thank you very much for listening.
Thanks very much, Phil. As always, very comprehensive summary of what we know so far. So we'll take the questions at the end. I just move on to our next speaker, Anna Andreou. Anna is a director in the headache unit or headache center, headache research center in Guy's and St. Thomas's, and she's also a senior lecturer in King's College. She's going to talk about what would potentially we may know in future about migraine pathophysiology. So Anna.
Thank you, Fayaz, for the kind invitation, and good evening, everyone. I hope you can now see my screen. So as Fayaz mentioned, I will be talking about some of the knowledge gaps and the future targets in migraine pathophysiology and treatment. So these are my disclosures, and the knowledge we have on migraine pathophysiology has, of course, advanced a lot in the past years, but there are still some knowledge gaps that I would like to emphasize. I cannot go through all of them. We were asked to prepare just 20-minute presentation, so hopefully I will emphasize just some important gaps that we can all work around them to contribute in the generation of knowledge in the future. And also I will touch some potential therapies that we may have hopefully our hands on in the next decade for migraine treatment. So as Phil mentioned, migraine, it's a very complicated disorder. It's not just the head pain that bothers the patients, but it's also all the other symptoms that come during migraine attacks, but also appear in chronic migraine when patients have absolutely no gap between attacks, and it's like a continuous headache, a continuous migraine attack with all of the other symptoms involved. And we like to call this an evolutive disorder because even within the migraine attack, different structures, different brain areas are involved with different symptoms at each phase. And then we have again in chronic migraine, different functional changes in the sensory systems involved in migraine pathophysiology. So starting with some of the known knowledge on migraine attacks is that we have different brain areas involved during the different phases of a migraine attack. And of course, we know that in between patients may appear normal, but as Phil mentioned, there are some sensory disturbances in these patients. And obviously, we know that genetic factors are some of the factors that influence migraine, but actually there is a multifactorial component in the predisposition of migraine into this different symptomatology. So when it comes to a migraine attack, we know that during the premonitory phase, so this is the early phase before an actual migraine headache begins, there is cortical and hypothalamic activation that potentially these days, especially the hypothalamus, is thought as the trigger of a migraine attack. Then for the patients who have migraine aura, we know that this is probably due to a phenomenon called cortical spreading depression that occurs in the occipital cortex. And then moving into the headache phase, we definitely know that there is activation of the ascending trigeminal thalamic pathway. And this is the pathway that drives essentially the head pain, the nociceptive signals that highlight the pain in migraine patients. So one of the knowledge gaps that I think we have in migraine pathophysiology is how is the migraine headache generated following hypothalamic activation? And Phil mentioned some of the structures already that potentially drive the symptomatology and the attacks. But essentially, there may be two ways that this can happen. So the hypothalamus may directly activate the trigeminal system and even induce cortical spreading depression by direct connections, or it may activate other brain areas, modulate them in a different way that they will then influence how sensory information is processed within the trigeminal system. And I think both ways are possible, but this still corresponds into the knowledge gap we have. So first of all, we can have direct modulation of the trigeminal cervical complex by hypothalamic areas. And one example is the A11 dopaminergic nucleus, which by having direct connections to second-order neurons within the trigeminal cervical complex can actually modulate the sensory information that comes in and activates the trigeminal thalamic pathway. And this dopaminergic nucleus, we know that it's susceptible to migraine triggers like the nitric oxide. Like when we infuse nitric oxide into animal models, and you can see that activation of this nucleus is affected by nitric oxide donors. At the same time, if we stimulate the 11 nucleus, we can directly facilitate nociceptive information from second-order neurons within the trigeminal cervical complex. Now, when it comes to indirect activation of the or modulation of the trigeminal cervical complex, this may involve brainstem activation, brainstem structures, since brainstem activation has been seen during the headache phase in brain imaging studies, and I'm sure Farooq will mention some of these. And this was actually seen in both spontaneous migraine attacks and in nitric oxide donors triggered attacks, again with nitroglycerin. So again, the migraine headache may be activated by the hypothalamus, either directly or indirectly through brainstem structures. However, I think the equation is not that simple one way or another, because if we try and look at gene alterations in the hypothalamus in the early phase of infusion of nitric oxide in animal models, and this can correspond in a way in the premonitory phase of migraine patients. And during this phase, there is a massive change in a number of different genes that may be involved in the modulation of the trigeminal system. And this include, amongst others, metal ion binding genes, glutamatergic synaptic signaling pathway genes, GABAergic signaling pathway genes, circadian rhythm genes, notch signaling pathways. All sorts of different genes can actually be altered in the early stages of a migraine attack, potentially, at least from the animal models. This is what we see. So I think it's very complicated to understand what sort of changes we have in the hypothalamic region that could alter then the trigeminal sensory processing along the ascending trigeminothalamic pathway. And we can go and look at individual nucleos like the 11 nucleos or individual peptides like the orexin peptides, but I think the solution will be probably more complicated and will involve a number of different pathways that influence each other in terms of having a complete modulation of the ascending trigeminothalamic pathway. Now, another knowledge gap that we have in migraine is if migraine is a brain disorder, and we did discuss, both myself earlier and Phil, that lots of brain areas, brain structures are involved, brain networks become dysfunctional. So if this is the case and migraine is a brain disorder, then why are peripherally acting drugs effective? And actually, for whom are they effective? So I will give you just two examples. I could have included here the clinical trial outcomes, but I'm a big fan of real world evidence data. So here we have outcomes of Botox in chronic migraine patients from the Headache Center, where we show that Botox is effective in about 65% of patients. And with the new CGRP antibodies that we also know that they don't cross the blood-brain barrier, I'm showing here an example with erenumab, again, real-world evidence, which was effective in about 50% of the patients. So obviously, these are the chronic migraine patients. They are difficult to treat patients in some cases. However, some of them do very well on these peripherally acting treatments, but others don't do well. So what is the mechanisms behind this? So perhaps one theory in migraine pathophysiology does not fit all patients. So perhaps we have different subpopulations of patients in which they have different mechanisms that it becomes prevalent for migraine pathophysiology. And these mechanisms will eventually give the same migraine phenotype with the premonitory symptoms, the aura, the migraine headache with all the known features and the sensitivity to light, noise, and so on. However, what may drive this migraine phenotype may be different. So in some patients, for example, in the patients where this peripherally acting treatments like Botox and the new CGRP monoclonal antibodies are effective, there may be more prominent peripheral trigeminal system activation or involvement of the peripheral trigeminal system. Then on patients in which these peripherally acting treatments are not effective, potentially brain dysfunction may be more prominent, sensory central dysfunction may need to be targeted in order to have an effective treatment for these patients. And again, this scenario may appear as too simplistic. Probably I should have added a third circle of other potential mechanisms that may be involved. And obviously, there are different factors that may drive one side or the other. And in patients where a peripheral trigeminal system may be more prevalent in driving the attacks, this may change, obviously, when they become more chronic, or if other factors influence their migraine condition or other comorbidities they may have. So I think one of the aspects in migraine pathophysiology that we need to understand better in order to perhaps discriminate which patients will respond better and for which treatment is the concept of central sensitization. So central sensitization is actually thought to drive chronic pain in general, not just chronic migraine. But it is important to remember that peripheral sensitization, this is when the primary trigeminal neurons in the case of migraine will become sensitized. They first become activated, then they become sensitized, which means that they have a hyperexcitable component, and they just drive activation from the peripheral trigeminal system to activate centrally segonorte neurons in the trigeminal cervical complex in the case of migraine. So the peripheral sensitization and the peripheral sensory inputs are important in driving the central pain. And following the peripheral sensitization, usually we have central sensitization, in which case the segonorte neuron becomes sensitized. And often, even if you remove, if you desensitize, let's say, the first order neuron, then the central sensitization remains sustained. And then in this case, a centrally acting treatment will be more effective in these patients with central sensitization in order to block this migraine chronification and hopefully bring the patient back to an episodic form. So one important aspect to remember when it comes to central sensitization is that it's driven by glutamatergic neurotransmission. And the reason I mention this is because when we go through the future therapeutics in a minute, targeting the glutamatergic system remains very relevant for migraine pathophysiology. Now, in terms of potential future therapeutics, I thought I would mention, given the time we have, just the ones for which, as far as I know, there has been some commercial interest. Obviously, there are multiple targets out there, and I think we still need to advance our research in looking for further therapeutics in migraine. So I will begin with one that you probably heard of already, and this is a monoclonal antibody or monoclonal antibody treatment against the PAGAP system. PAGAP, you may know already, it's a neuropeptide again. It's widely distributed both peripherally and within the brain, and it's involved in neuroprotection, neurodevelopment, nociception peripherally, and inflammation. And the reason PAGAP has been investigated as a potential therapeutic target in migraine is because PAGAP levels were found to be elevated in migraine patients, and intravenous infusion of PAGAP38 was shown to trigger migraine-like attacks in patients. So recently, there have been two monoclonal antibodies against the PAGAP system. The first one was a PAC1 monoclonal antibody, which went through a phase 2 randomized double-blinded placebo-controlled study in chronic and episodic migraine patients, which, however, stopped because this treatment was found ineffective in the early analysis. And the conclusion by the authors is that the PAC1 monoclonal antibody AMG 301 offered no benefit over placebo for migraine prevention. And further studies are needed for the role of PAGAP in migraine pathophysiology. So this is again something quite relevant that we need to keep investigating in migraine. However, there is still some hope for PAGAP monoclonal antibodies in migraine treatment, as another monoclonal antibody against PAGAP itself, not against the PAG1 receptor this time, but against PAGAP itself, has already gone through a phase 1 safety and tolerability study and was found to be quite safe and tolerable in humans. And this has now been bought by Lundberg, which at least in its investor relations information, they say that they're keen to keep the clinical trials active for this PAGAP monoclonal antibody with expected outcomes if the phase 2 study goes well by 2025. Now, another potential treatment that we may have to use in the future, and this is one that I have a particular interest in, is recombinant botulinum toxins. So when we're talking about botulinum toxins, you probably know that Botox is an effective treatment for the prevention of migraine. However, it does have some limitations, and the major limitation is that it's paralytic. So as a paralytic agent, it means that we're very limited to the amounts that we could use in patients, because increased paralysis also means increased toxicity, given that Botox is one of the most toxic molecules found in nature. Hence, the dose of Botox perhaps limits its efficacy in migraine patients. So when we're talking about botulinum toxins, these involve 3 different domains. As a protein, it has 3 different domains that you can see here. And you have to think of these domains as some Lego parts. So if you think of this as Lego parts that we can take apart, different laboratories and my collaborators in Sheffield actually managed to take apart these different domains and restructure them in a different way that give a botulinum toxin molecule that has exactly the same domains, hence the same characteristics as botulinum toxin, but it either has advanced super efficient properties, or it becomes non-paralytic. And it becomes non-paralytic because the way the different domains are put together, they change the structure of the molecule in space, and hence this molecule becomes now too big to actually enter the tight neuromuscular junction. And we had some very good results in the lab that we published recently with these advanced recombinant Botox molecules. If you look here, we use what we call the Botox AA molecule. So this is an advanced super-efficient botulinum toxin molecule with 2 binding domains. This means that it becomes more efficient in binding to the synapse and in cleaving SNAP25, as you can see here, compared to Botox. And also when we recorded EMG in big muscles in animals injected with Vitox AA, this molecule had significantly reduced paralytic activity compared to Botox. Now, when this molecule was injected in the trigeminal territory of animal models of migraine, we found that it actually reduces the nociceptive activation thresholds of the trigeminal ganglion neurons. And at the same time, we found that it clips SNAP25 in peptidergic and non-peptidergic neurons. And when we say peptidergic, we do mean also in CGRP expressing neurons, as you can see here. So overall, this is a very efficient treatment, at least in the animal models, which has some commercial interest earlier. And this is a field we need to look for in the future for further advancements, given that using this biochemical synthesis of breaking and putting back the molecule together, lots of other stuff can happen. And for example, one of the molecules we'll be looking at in the future is a receptor-targeted botulinum toxin. So imagine if you had a botulinum toxin that specifically targets CGRP-expressing neurons, for example. So this is something very exciting, and I think this might be one of the future projects or future therapeutics that we may have our hands on for our patients. Another study looking at acute treatments for migraine is one looking for the HCN2 ion channel, which is considered as the pacemaker of pain in nociceptive neurons. So this channel is sensitized by cyclic AMP, which, as you know, is elevated in migraine, and essentially this is what even the CGRP antibodies will target. So the channels are sensitized by cyclic AMP, and this results in increased excitability. So potentially these HCN2 channels may even be the peripheral pacemaker of pain during the headache phase in a migraine attack. So in my laboratory, along with our colleagues and collaborators in our laboratory, Professor McNaughton at King's College, we use HCN2 knockout mice, and we found that in these mice, acute GTN, again, the nitric oxide model of migraine is reduced. So it reduces sensitization in this model of migraine. And if we block the HCN channels in naive animals that have gone through chronic exposure to GTN, which will normally induce sensitization, this sensitization is reduced when ivabradine, an HCN block antagonist, is introduced in these animals. Now, finally, I did mention earlier that central sensitization potentially is an important factor in migraine pathophysiology and in the chronification of migraine. So we do need to target central sensitization. And this is, as I said earlier, driven by glutamate. And glutamate is the major neurotransmitter that drives activation of both the peripheral and the ascending trigeminal thalamic pathway. And we know that glutamate was also found to be increased both in the CSF and in serum levels in migraine patients. So it does have a good rationale of why we should be, there is a good rationale of why we should be targeting the glutamatergic system. However, the glutamatergic system, it's complicated. It includes a number of different receptors, both inotropic and metabotropic glutamate receptors. And because of its abundance in the central nervous system, targeting glutamate globally could induce serious side effects. One of the receptors that was found to have some potential interest with reduced side effects is the kainate receptor. And I spent my whole PhD actually looking into this receptor, and it was found to be very important in driving trigeminal nociception, both in the periphery, on second order neurons, on third order neurons, and even on the cortex itself. And Ella Lilly at some stage did develop what they thought a specific kainate receptor antagonist, which was called the LY466195 kainate antagonist. However, when this was tested in animal models, we found that it was actually a dual kainate and AMPA receptor antagonist. So although this treatment was found to be effective in relieving head pain in migraine patients, there were still some side effects that I believe were driven by the AMPA antagonist side of this molecule. And hence, a more selective kainate receptor antagonist may still represent an important target for future therapeutics. Some of you may also know of some efforts in targeting the metabotropic glutamate system in migraine with an mGluR5 antagonist. However, again, this is not a very viable option, given that it also had some side effects. So a potential way forward might be to indirectly modulate the glutamatergic system, and an indirect way is through the tryptophan-kynurenic pathway, which is the second most prevalent metabolic pathway of tryptophan. And also, kynurenic acid has been shown to be elevated in the serum levels of chronic migraine patients. And antagonists of and the kynurenic acid actually can act as an antagonist of ionotropic glutamate receptors without globally blocking glutamatergic transmission. So it's acting mainly on the NMDA receptor. And in animal models, it was shown that the kynurenic analogs could block activation of the trigeminal pathway and prevent again sensitization induced by nitroglycerin and hyperalgesia, and also suppress increased levels of CGRP, nNOS, and different cytokines in the trigeminal system that we know are potentially involved in driving activation during the headache pain. What is interesting is that now kynurenic analogs and kynurenic acid itself has been used in phase 1 clinical trials, which was found very safe, and potentially we will see some future clinical trials in migraine patients looking at the efficacy of these kynurenic analogs in migraine prevention and in the acute treatment of migraine. And with that, I finished. As I said, we can't go through everything in just 20 minutes, but in conclusion, we can say that knowledge is power. So if we do understand migraine pathophysiology, we will further improve the therapeutic options for migraine patients, as we have done already with the knowledge we gained so far. The current migraine treatments are very effective, but we all know that these are not the cure. Hence, we do need to invest more research in finding future targets for both the acute and preventive treatment of migraine. And with that, I thank you so much, and I'm happy to take questions after Farooq's presentation at the end.
Thank you very much, Anna. That was very comprehensive. Something new that I have learned about emerging therapies, and we'll look forward to PACAP coming soon. I think that will be the next one. So we go for the last talk of the session, Farooq Maniyar. Farooq is a consultant neurologist in the Royal London Hospital and Barts NHS Trust. He is the winner of the quite a prestigious Harold Wolff Award from the International Headache Society. So it's very nice to see his work on the premonitory phase of migraine with the functional imaging. So he's going to bring some clinical perspective of the pathophysiology of migraine. Farooq?
Well, thank you very much, Fayaz. Thank you, Bash, for the opportunity. And it's a pleasure to be here speaking on this forum. So these are my disclosures. Fayaz, can you hear me all right?
Yeah,
Fayaz,
yeah.
can you hear me all right? Yeah. Hello.
Yeah. You're okay. I can hear you well. I think we haven't had any complaints yet.
Okay. All right. Okay. Excellent. So these are my disclosures. So I'll start off with this slide. I'm obviously going to be speaking about the human evidence of change of species from the experimental animals onto the human evidence, human studies. So migraine, of course, we identify migraine attack as the headache, and I call it migraine is headache with character. So that distinguishes this from tension type headache. So it's not just pain, you've got other features to go with the pain in migraine. So the nature of the pain, the throbbing pain, nausea and vomiting, you get a lot of sensory disturbances essentially. So sensitivity to light and sound and smell and movement. Essentially, patients prefer to obviously sit and relax. But also, in addition to that, there's a lot of brain fog, cognitive symptoms, tiredness, mood changes. Sometimes these symptoms can be in excess to the pain. I mean, the pain device is 4 out of 10, but they're still not being able to function normally, clearly suggesting there is a lot happening in the brain, and it's not just pain. Furthermore, what we also need to appreciate, I think, a bit more perhaps, is that before the headache starts in migraine, many patients will also experience a lot of symptoms telling them that they're going to get a migraine. Some of the symptoms are obviously noticed by their spouse or their colleagues, because there's a mood change particularly. And that tells them that, oh, stay away from this person, don't mess around with them now because he's going to have a migraine in the next hours, and sometimes up to 72 hours before these changes can occur. Again, suggesting that a lot of the initial change is likely to be in the brain. Look at the symptoms: mood changes, yawning, cravings for things, chocolate, coke, things like that, is likely to obviously originating from the brain, essentially. Migraine aura, as we know it, cortical spreading depression, as the biological correlate, does not have a faithful relationship with headache. It can occur before headache, the typical attack, but it can also occur during headache or without headache as well. So it's possible that those two mechanisms are parallel rather than one leading to the other. This is the attack, and migraine is episodic. So you get episodes of these attacks in somebody who is genetically predetermined to get migraine, because clearly there's a strong family history. Now we have seen the biological areas, which are driving this. So obviously we've got the central structures which are modulating the peripheral traffic from the trigeminal nerves, essentially. And then of course this TCC, the trigeminal cervical complex activity, can be influenced by the C2 and C3 inputs as well. Probably the reason why the greater occipital nerve block, which targets C2 and C3 nerve roots, is effective in reducing symptoms in some patients, not all patients. The question, of course, is what are the main mechanisms? Are the peripheral mechanisms the main thing that's driving the process, or the central areas, or is it, as my colleagues have mentioned, that we may have to look at both? So this is what I'll be talking about in the next few slides, and of course presenting to you the human imaging, particularly imaging evidence to understand this. So this slide summarizes the functional imaging studies and activation patterns during acute migraine attacks, including spontaneous migraine and nitroglycerin-induced migraine attacks. The findings are very similar. The headaches that people get with nitroglycerin are very similar to their spontaneous migraine attacks. what is clearly seen and consistently seen is activation of the dorsal pons in the region of the locus coeruleus, particularly, which is a common finding in all of these studies. Interestingly, when you treat these patients with sumatriptan, when the pain goes away, you still get persistence of this dorsal pontine and brainstem activation, although the cortical activation, particularly the cingulate cortex here shown, for example, here, there are many other areas that are activated as well. The cortical activations go away, suggesting that's a reaction to the pain. What we did was we took a step earlier, and we actually looked at patients during the premonitory phase. So we know what the migraine map is like during migraine headache, but we went a bit earlier. And we found activations in the dorsal pons like we have seen before during migraine headache. But in addition to that, we also got posterior hypothalamic activation, the posterior areas of the midbrain, the region of the periaqueductal gray, and of course the dorsal pontine activation, and a lot of cortical activation, occipital, temporal, and frontal. Now remember, this is happening before the headache has started. Okay, so in our experimental setup, of course, a few hours, typically premonitory symptoms can occur up to 72 hours before the headache has started. So there's a lot of activation that is happening in the brain even before the pain has started. And one really needs to keep this in mind when we try to understand the evolution and the origin of the attack. So this is a different study. This is a functional MRI study, and the authors have scanned these patients at different stages of migraine. So interictally, immediately prior to an attack, and immediately following an attack, and compared with controls. What is interestingly seen here is that all of those regions that I referred to, so the pain modulating areas, the dorsal pons, the PAG, and the hypothalamus, and the pain transmitting areas, if you like, the spinal trigeminal nucleus and thalamus, they all are activated more compared to controls. But the striking thing is that look at the maximum levels of activation in all of these areas. That is happening in this red bar, and that is immediately prior to an attack. So clearly something is happening before the attack has started, and that is within the brain, and that is within areas that we know modulate TCC activity, including the hypothalamus, the PAG, and the dorsal pons. This is a slightly different way of looking at a similar sort of question, answering this question. This is a fMRI study, 7 patients. They were scanned every day. So brave patients, they were scanned every day, and actually they had this gaseous ammonia stimulation. So there's external stimulation here. This is not a resting state study, but in response to an external stimulation, which is gaseous ammonia painful stimulation. And what we are seeing here is comparison of the premonitory phase versus interictal phase. And again, there is activation of the hypothalamus, which again is the highest level is in the preictal or the premonitory phase. Now, this is a fMRI study, 20 patients, similar design, gaseous ammonia stimulation, and the region of interest here is the spinal trigeminal nucleus. And it was shown that the response of the spinal trigeminal nucleus to gaseous ammonia was the highest in, again, the preictal phase, the premonitory phase. So you can see there's a recurring theme here that the spinal trigeminal nucleus is more sort of facilitating at this stage before the headache has started, essentially, to external pain as well. So the whole trigeminal system has been sensitized at this time before the headache has started. Furthermore, interestingly, the authors also showed that you could actually predict the next attack depending on the level of the response in the spinal trigeminal nucleus. So the higher the level of the response, as you can see here, the shorter is the time to the next attack. So 4 days here compared to, say, 16 days here. And that is really interesting. So we don't know these patients whether, what sort of triggers they're going to get exposed to in 4 days' time. But before that has happened, we have been able to predict that they will be getting an attack in about 4 days' time. And there are other studies, which I'm not showing them here due to time constraints, which have tried to predict the next attack on the basis of a lot of mathematical and sort of functional connectivity calculations of different brain areas, which probably suggests that there is a biological rhythm and there is a cycle and there is a rate of that cycle which drives the attacks. Phil mentioned this, which drives the rate of the attacks. That probably explains why some people get one migraine a year and some people are getting one migraine every week or even more, essentially. And perhaps there are times when this process is activated, the pro-nociceptive, as we mentioned, pro-nociceptive phase is activated. And within that phase, of course, certain things probably can, we can talk about that, the triggers part essentially, but there are certain times when a person is more vulnerable and there are certain times when a person is not vulnerable, which certainly would be in keeping with our clinical observation. As a clinician, when you talk to patients, they will tell you, yes, doctor, yes, stress can be a trigger, but I was more stressed 6 months ago. I had no migraines then. And now, yes, I am stressed, but I'm having migraines, so I don't really understand. And similar things with all of the other triggers that we talk about, and we'll talk about that. But this, I think, is a very interesting finding, is a part finding of this study. But I personally find this even more interesting than the fact that you actually have got more facilitative responses in the trigeminal nucleus before the headache started, which we have seen other studies showing the same findings. This is another fMRI study. Now, this one single patient was scanned every day for 30 days, and they captured 3 migraine attacks. And they actually did the fMRI in response to gaseous ammonia painful stimulation. Furthermore, using the coordinates that we showed in 2014 for the hypothalamus and some other colleagues in Daniel et al. In 2007, using those hypothalamic coordinates as a seed, the authors further showed that there's increased functional connectivity between the hypothalamus and the spinal trigeminal nucleus in the preeclamptic phase. So there's a clear evidence of a top communication between the hypothalamus and the spinal trigeminal nucleus. Now, Phil and Anna showed that there's a lot of modulatory activity of hypothalamus on the spinal trigeminal nucleus. So one can propose that this communication between the two perhaps represents a dysmodulation or the removal of an anti-nociceptive effect or something on those lines. Of course, there's a limit to what you can say on the basis of imaging studies, but this is the lesson we can derive from that, which then heralds the migraine attack. And during the headache phase, the ictal phase, there was increased functional connectivity between the hypothalamus and the dorsal pons, again suggesting that all these areas that are activated are also talking to each other, communicating with each other. Now, this is a study, fMRI study, which is showing functional connectivity of the periapical gray. And again, it is shown that it increased FC, connectivity between the thalamus, the hypothalamus, and other areas of the PAG. Again, suggesting here that the connectivity levels are the highest immediately prior to an attack. So it's a cyclical mechanism which peaks before the headache starts and then goes down, and then further goes down in the interictal phase, and then the cycle sort of starts again. Now, this is a functional connectivity study using the hypothalamus as a seed, and again it shows increased connectivity between areas that we know are important, including the nucleus coeruleus, which is the dorsal pontine nucleus, which is activated consistently during migraine attacks, and as we have seen also before migraine. Now, I must say, I have added this study here. The reason is that this was actually a negative study. So these authors, they tried to replicate those studies using PAG as a seed, and they did not find any increased functional connectivity. They did not study the hypothalamus, so one cannot make a comment on that. But as you can see, the frequency of the attacks in this study was 12 per year, so 1 per month, for example. In the previous studies, it was about 3 per month. So 36 attacks in a year in the previous studies, 12 attacks in a year in this study. So it might be a data, there's probably less sort of data here, essentially, in terms of migraine attacks. Furthermore, this is a study that has included only migraine with aura patients. And not only that, all patients have to have attacks preceded by aura, essentially. Now, in my experience, certainly, and certainly in the literature suggests that that's not a common scenario. Even in patients with migraine with aura, if you look at all the attacks that they experience throughout a lifetime, majority of the attacks will be actually with migraine without aura over a period of time. So a lot of times the aura settles down, but the migraine headache continues essentially. So that is, I think, not representative of the larger population. But I mean, I just wanted to show that not all functional connectivity studies are replicated. So to summarize, as far as human evidence is concerned, we have seen increased activations during the premonitory phase of all these areas, that we talk about when teaching medical students. Actually, we have seen activation of those very areas in humans, in PET studies that we published, and also fMRI studies. We are seeing this activation in spontaneous attacks as well as in response to external stimulation. We are looking at increased responsiveness of the trigeminal nucleus before the headache starts in the premonitory phase. We have seen increased functional connectivity of the hypothalamus with the trigeminal nucleus, as well as the dorsal pons, and the increased functional connectivity of the PHG and with the hypothalamus. So clearly suggesting that before the headache starts, there's a lot of activity that is happening within the brain. And that is driving, certainly in my opinion, that is driving the process. That is the main process. And that, of course, explains not only the eventual appearance of pain, but also the symptoms that actually happen before the pain starts, which is the premonitory symptoms. So the hypothalamus is in a prime position to cause symptoms like yawning due to the release of dopamine, increased maturation of thirst, ADH release, for example. Mood changes, the hypothalamus is intricately connected to the limbic system. Mood changes can certainly occur due to hypothalamic activation. Cravings certainly can occur. Anna very nicely showed the A11 nucleus having this anti-nociceptive action on the TNC, trigeminal nucleus Coeruleus, which also receives input from the C2 and C3 distributions, essentially. So it is possible that if you remove that anti-nociceptive effect, you will lead on to stiffness and pain in the C2, C3 distribution, causing the neck stiffness. And certainly, neck stiffness is a very common first symptom in my patients. And I always ask this, extremely common. Perhaps that's the reason why many of our patients are then, siphoned off to spinal surgeons and chiropractors because the problem is in the neck. It's not. It may start, the pain may start in the neck and radiate anteriorly, but there's a biological explanation for that. It is still migraine. And we'll talk about triggers in a bit. So triggers of migraine. I'm sure all of you will have come across patients who will tell you, doctor, what is my trigger? I know it's migraine, my GP told me it's migraine, but you now tell me what is causing the migraine. What is the one thing that I need to keep away from and I'll be migraine free? Unfortunately, we often do not find as one single thing that can actually make our patients migraine free. Moreover, question is, actually, are the triggers or are the triggers actually premonitory symptoms? For example, a gentleman goes off and has a Chinese meal somewhere or another kind of meal of the orange, for example, or citrus fruits, for example, often treated as triggers, and they feel nauseous and then develop headache essentially. And they'll say, I felt nauseous because I had that meal or the orange, and then obviously the headache started off, so the whole thing is a trigger. It could also be that these patients have actually activated certain areas in the brain that has caused the nausea as a prominent premonitory symptom. So here we compare those with nausea versus those without nausea in the premonitory phase in the absence of pain. And we show activation in the upper dorsal medulla, which contains important nuclei, including the dorsal motor nucleus of vagus, the nucleus tractus solitarius, which are all been intricately shown to be involved in nausea. So the nausea patients are activating this, the no nausea patients are not activating these areas. Perhaps that is the reason why the nausea occurs in some and not all. Similarly, doctor, when I get exposed to light, I get a migraine. Or is it that you are actually experiencing the light more bright and more sort of troublesome because you are activating the visual cortical areas more than others? And certainly this is what we showed in those with photophobia versus those without photophobia. Now, I must say, it may not be as simple as that. There may be a bidirectional relationship between these physiological changes and migraine. And again, Phil mentioned this very nicely. And I certainly agree with that. My own concept on this is that migraine patients go through phases where they are in a pro-nociceptive phase, not just in pro-nociceptive, probably not the right thing to say, pro-migraine phase, because migraine is not just pain. So pro-migraine phase, so they are vulnerable in that time. And in that time, if there is a trigger at a particular level, or combination of different triggers, not sleeping well, stress, not eating well, alcohol, all of those triggers come together, they can actually tilt the balance, cause a migraine attack. Whereas other times, they have actually been exposed to the same kind of triggers, it has not caused a migraine. So the internal rhythm is important, but physiological changes around patients can also be important. But I think it's important to give the right biological advice, scientific advice to patients, that often it is not just external things. So you are trying your best, but you're not going to find one or two things that you keep away and you're not going to be migraine free. I think it's important to give that information. Some people don't like it, but that's the truth, I think. Now, so what does it mean then? I mean, we talk about migraine central factors. How about peripheral factors? So Masood Ashina, Professor Ashina, one know very well, gentleman and a great migraine researcher. He's now published 3 reviews in Lancet, and I would certainly recommend all those who are interested to read this. Now, I'll start off with this, and Masood very nicely shows this this cartoon where he has shown that peripheral provokers of migraine, there are things that can inject intravenously and that causes migraine in patients with a history of migraine, doesn't cause migraine in controls. For example, the earliest one was nitroglycerin, and we use the same agent, by the way, in our studies. 80% of patients will get migraine. PACAP, 58% patients will get migraine. Probably that was the reason why people have gone on and done the monoclonal antibody study with PACAP. About 57% patients will develop migraine after CGRP, and then 86% with silestazole and sildenafil, 83%. Now, the common thing between all of this is that they're either cyclic AMP or cyclic GMP activators, which then lead on to ultimately opening of potassium channels. So this may be the final pathway, the opening of the potassium channels may be the final pathway in the cascade. And indeed, actually, when you give this leucomacalim, which is a potassium channel opener, everybody gets migraine. So 16 patients had this infusion, all 16 had migraine, only one of them had migraine after placebo. And similarly, 95% developed migraine after this related substance, which is also a potassium channel opener. So, but what does that mean? A couple of things here. Firstly, none of these agents trigger premonitory symptoms. They trigger pain, of course, not trigger premonitory except nitroglycerin. PACAP, CGRP, do not, and leucomacalim, ATP donor basically, potassium channel opener, does not trigger premonitory symptoms, number one. Number two, if vasodilatation is the main thing, we've got another vasodilator called vasoactive intestinal polypeptide. Polypeptide does not induce migraine attacks. Now, this is obviously the experimental study, but how about migraine patients? So this is a study in 2008, Schulman et al. They showed in nitroglycerin-induced migraine, there is no appreciable increase or vasodilatation in the extra or intracellular arteries in migraine. In 2013, Amin et al. Showed, again, Masood Ashina's group essentially showed that there is no significant vasodilatation in the external extracranial cerebral arteries. There is very minimal vasodilatation of the internal cerebral arteries. Furthermore, if you look at other agents which are useful in acute migraine treatment, for example, lasmiditan is a 5-lasmiditan, 5-HT1F agonist, does not have action on 5-HT1B receptors, therefore does not cause vasoconstriction, but equally effective as triptans, making about 30% patients pain-free at the end of 2 hours, compared to triptans, which obviously are vasoconstrictors. Similarly, CGRP antagonists, not antibodies, antagonists can also be effective in acute treatment of migraine. And CGRP antagonists do not cause direct vasoconstriction. Now, I must say that some people argue that although they do not cause vasoconstriction, they may prevent vasodilatation. Essentially, therefore, there may be an element of vascular effects. But the point I'm making here is that the vascular theory, i.e. vasodilatation, is not consistent finding, and I find it difficult to put all of this together in a way that gives me a consistent signal that is necessary for migraine pathogenesis. Certainly, we see here that vasoconstriction is not necessary for acute treatment of migraine. For example, lasmiditan and ranibizumab proves that. Furthermore, to my mind, if we take vasodilatation as the primary event, as the authors suggest here, which then stimulates the trigeminal nerves, well, one then has to propose, if that's the mechanism, that's the first step, and the peripheral trigeminal nerve is stimulated, then the central connections of the trigeminal nerves to the second order neuron and the third order neuron and the cortical representation, and the cortical areas that they project to, are then responsible for the premonitory symptoms. Because remember, premonitory symptoms can take up to 72 hours before the headache starts. So to me, it is not plausible that the peripheral trigeminal nerve stimulation causes all of these symptoms through the central processing for days before it actually causes pain. For me, it is much more likely that the central processes, the central changes are the ones that drive the initial process, and they may also drive, for example, the superior salivatory nucleus involvement in the brainstem can drive some of the peripheral vasodilatory effects, and that can perpetuate the pain part of the problem. So I think that's what I have to say. Just to summarize, we are clearly seeing in various different ways, whether you look at direct imaging, functional imaging, of course, the premonitory phase, or indirect activation through external stimulation, whichever we look at it, is clearly a strong signal that central areas are activated before the pain starts. During migraine, the cyclical nature of this activation, the hypothalamus is very important. And it's possible that there's a biorhythm going on in patients who are genetically predetermined, and certain things can trigger symptoms as well if they come together at a time when patients are vulnerable. And as far as peripheral effects are concerned, there can be peripheral effects, and we can modify this. For example, great hospital nerve blocks, Botox, even the CGRP antibodies. At the moment, there is no firm information that it acts centrally. But then I wonder, what can we achieve? What actually can we achieve? We do find something that safely enters the brain and affects the area that actually causing the problem. What more can we achieve? We'll probably see, it's complete speculation, but we probably will see much more than the 60%, the 50%, and the 65% response rates that we see in our patients. Thank you very much for your attention. I hope you find this useful.
Thank you very much, Farooq. We got some time to take a few questions. So I think the first one to come to you, Farooq. Somebody asked the question that migraine with aura have got a high risk of stroke. Does that support the vascular theory of migraine?
No, so the migraine aura risk of stroke, of course, applies to only a subset of population. One is females of reproductive age group. There's a relatively increased risk, and the risk, of course, increases further on if you add on things like estrogen and smoking and things like that. I think it's a genetic link. It's not to suggest that therefore there are vascular changes that occur. As far as migraine attacks are concerned, there may be a common genetic link which predisposes these people to have strokes. That's what, my belief is.
Okay, the other question was, I was going to ask Anna, could this is possible that pain is peripheral and all other symptoms of migraine are central?
Well, even in patients where the peripheral blocks, the peripheral acting treatments do not work, and the pain is central, we know that the central pain still, in every other pain condition, it still requires a peripheral drive. So yes, there is a very strong potential that the periphery is a major player in driving the pain. And as you said, all other symptoms may be central and may contribute in how the threshold becomes lower in the brain in order for this trigeminal activity that should have been otherwise normal to be sensed as abnormal. So it becomes hyperexcitable, perhaps because of all of these other central events that are happening in the brain. But certainly with all other pain conditions, the peripheral drive is the major drive for the pain phase of any disease.
Thanks, Anna. So Phil, somebody from Iran asked the question, are there any studies investigating orexin in migraine patients?
The answer to that is unfortunately yes. And why I say unfortunately is because actually the study design was very poor. All the research suggests that it's actually activation of this pathway, so promoting arousal and actually activating the orexin A that I spoke about that would be anti-nociceptive. The one clinical trial that has been undertaken was a drug that's been approved for narcolepsy. So it was a dual orexin receptor antagonist. So it was actually blocking the system. And unsurprisingly, it failed for migraine. But most of the approaches these days are either for an agonist to activate that pathway, the anti-nociceptive arm, or a modulator that can modulate the pathway, much like, you know, SSRIs would for normal serotonin signaling within the brain.
Okay, one more question, Phil. Just being inquisitive about why the migraine is something that progresses. Why don't all the symptoms happen all together at the same time? Is there anything in the pathophysiology that tells us why it marches from one to the other?
It's a very important question, and I think it touches a little bit on what Anna was saying as well. It's probably individual to the specific person, and you'll see a different series of features. Obviously there's a generality, but any one feature, like for example in the graph that Farooq showed, where you get the premonitory symptoms and then you move into the aura in some patients and then onto the headache, you get this varying intensity of the different systems, and that's probably down to an individual person. And really it's probably, again, what's driving that attack in that patient. We speak about this from either a central or a peripheral drive, but also within a specific central network. What's that first sensory system, and then that starts to build the system, and then you start to get engagement of these other symptoms as the network becomes more dysfunctional and more sensory disintegration or dysprocessing, dysfunctional processing. So that would be my personal view on that. I see Anna's got her hand up.
Well, I just wanted to add, thank you, Phil. I just wanted to add that I think it's a mistake to see migraine pathophysiology as one stable aspect, as one stable thing. Migraine pathophysiology is an evolutive phenomenon. So it changes in a migraine attack, it changes from episodic to chronic. So it's very important that we don't just focus on one aspect of the migraine pathophysiology and say, this is it. We need to look at migraine as a disorder that evolves both within an attack, but also within the patient and over the years, over the lifespan of a migraine patient, we do see changes in the symptomatology of migraine, which potentially means that the pathophysiology has evolved to a different state, with other factors being more important at a later stage in a patient's life. So I think it's very important that we don't see the pathophysiology as one status that remains constant the whole time.
I think that's probably the most valid explanation. Farooq, I've got a question from Norwich. Alex Valoria, our friend, he got particular interest in cervicogenic headaches. The question is, head pain can be provoked and relieved by cervical examination and blockade of local structures. How is that cervical rehabilitation can improve migraine and many other headache phenotypes?
Yeah, I mean, as I said, you know, there is the C2 and C3 dermatomes essentially will communicate with the trigeminal nerves intracranially in the medulla, essentially, as the sensory ascending pathway goes up, essentially. And this common projection on the trigeminal cervical complex explains why the TCC activity can be modulated, essentially. So either can be brought on, but if you stimulate in a particular way, but if you block the action, of C2C3 with a nerve block, it can reduce the effect as well, and that's why we find redox with nerve blocks useful. I don't think it's a specific migraine effect. It's an anatomical truth. You know, the C2C3 and TCC common projection is an anatomical truth. So you can utilize it for cervicogenic headache. It helps tension type headache. The nerve block helps. And similarly, you know, you can utilize chiropractic or physiotherapy, neck mobilization for all of these disorders, and it can be useful. Just to highlight a point here, it's a good point to make, I guess. I cannot emphasize this enough. The amount of people with neck pain and stiffness who go to a spinal surgeon and get diagnosed as tension type headache or cervical pain or something, you know, because we do MRI scan of the cervical spine. What happens? Everybody after the age of 20 will have some degenerative changes. And if you start treating the facet joints and the dehydration of the discs and this and that, everybody is a candidate then, essentially. I mean, so it's very important to understand that neck pain and neck stiffness can be a premonitory symptom. It's a very common migraine symptom, and is, in my experience, the most common first symptom of migraine.
Okay, one more thing, Farooq, that I wanted to ask you. I mean, you've done a great work with the premonitory symptoms and the functional imaging. Have you found a difference in the episodic versus chronic migraine sufferers in the premonitory? I mean, do they stay in the premonitory phase forever?
And that's a very good question, Priyaz, to ask. And that's a very good question. Well, I mean, of course, I mean, study-wise, our study was obviously in episodic migraine, and we obviously triggered migraine. So it was experimental migraine, if you like, because it's very difficult to otherwise get PET scans for people, you know, when they feel they're going to get a migraine. I'm not aware of any studies in chronic migraine essentially having being done in the premonitory phase. So it's difficult to give you some evidence on that. It is. I mean, chronic migraine for me is a condition where you get very repeated activation of this migraine cycle. And it is possible, like Anna alluded to it, you know, that in between the attacks, you get this central sensitization. So you always tender, you're always painful, you're always achy. And then on top of that, you get the attacks essentially. But I'm not aware of any premonitory study in chronic migraine.
Yeah, I think all of your patients in your study were episodic migraineurs, wasn't it?
That's right. That's right. Yeah.
Did you have any division between high frequency and low frequency, or they were all low frequency migraine?
No, they had to be low frequency, Fayaz, because remember when we did our study, you know, when we got them for the scan and we gave them nitroglycerin, they had to be free of any premonitory symptoms 3 days before that, right? Because we had to induce premonitory symptoms as a new attack so that we can freshly scan them. So they had to be free of any premonitory attacks for 3 days before. So that essentially means that you cannot have a patient for having more than a certain number of attacks a month, because otherwise you'll never be sure. And by definition, they'll have, you know, some patients will have premonitory symptoms before the nitroglycerin infusion. So we had to choose people with low frequency migraine attacks for that reason.
There's a very interesting question. I'm going to put it to Anna. Why some patients lose the peripheral symptoms as they get older and just left with the aura or visual symptoms? I think you're mute.
You're mute, Anna.
Thank you. I was just saying that the simplest answer is that we don't know. This is another gap in our knowledge of migraine pathophysiology. But potentially, as we get older, as I said, because the migraine is an evolutive disorder that changes and different systems become more prominent during a patient's lifespan, perhaps the peripheral trigeminal system is no longer that important, but then central mechanisms remain relevant in migraine patients when they're aging. So perhaps that's why they don't get as many headaches. Although I have to say, at least at the headache center, there is a big population of elderly migraine patients. So perhaps, again, there is no one question for everyone. One answer, sorry, for every patient.
Yeah, you're right. Another interesting question. What's the main, well, I'll put it to Phil. What is the main pathophysiological mechanism of olfactory trigger for migraine headache? Can osmophobia tell us about migraine?
So I think the first thing to press there, based on what we've seen today, is that these triggers might not be triggers. So you've heard it from Farooq, you've heard it from Anna, and I'll say it as well, that actually a lot of the time, many of these figures are actually part of the attack. The attack has happened and starting 72 hours plus before the headache phase. So the patients are misinterpreting these triggers, of course, as that, when really they're part of the premonitory symptom. The brain is already, the network is already dysfunctional, and we're starting to get this heightened response. But of course, we do know that there is a link on the other aspect from the nasal neural networks, because some of our colleagues, for example, Arno May in Germany, they actually use intranasal stimulation to drive activation of the parasympathetic pathways as they study cluster headaches. So there's clearly a link between, noxious stimulation of the nasal passage and parasympathetic pathway, which can feed into the migraine trigeminal system as part of this trigeminal autonomic reflex. So there is some pathophysiology there, but in a lot of the patients, I would suggest it might be that they're mistaking these premonitory symptoms for triggers.
Well, let me ask you then another question, which is my problem. A lot of people get migraine when they are stressed. Okay, I get migraine when I am relaxed after stress. So I might get a migraine now after the webinar finishes. Is that a trigger or is that a premonitory symptom?
Yeah, so there was a really interesting study a number of years ago now by Richard Lipton, who actually looked at stress, particularly in context of migraine. And what they actually showed was that it wasn't actually a change in stress per se. It was a change in the person's perception of the stress they were under that was more predictive of their having a migraine attack. So again, it would fit in nicely with this story about it's how your brain is responding to that stress based on the state that you're in. So you might be more susceptible being triggered by that stress, or you might be less susceptible based on the cyclic variability that you've heard from the three speakers today. So it's very likely that in some people, stress might have an effect. There is some lovely animal work come out of the group in Boston showing that if you stress animals, you can actually tip that pathway towards a pro-nociceptive pathway, and you can inhibit the anti-nociceptive component. So there is a pathological mechanism whereby stress can tip these animals into a pro-pain state away from an anti-pain state. So there is a mechanism there. But again, clinically, I think that study by Richard Lipton was a really beautiful study showing that it's about the perception of stress that's key.
Yeah.
You have to add anything, Farooq?
No, I completely agree. I mean, certainly, I mean, as you said, Fayaz, you said relaxation from stress, but what I clinically see from patients is, and some of the experienced migraine patients have noticed this, that the relationship with stress is not a consistent thing. Sometimes when they're very stressed or relaxing from stress, they get a migraine, but many times they don't get migraine. Therefore, it puts us back to this situation where there are certain times when the migraine system is pro-nociceptive and like I said, pro-migraine, not just nociceptive, pro-migraine. And at that time, certain things at a particular threshold can induce a trigger, can induce an attack, but not always.
Okay, just the last question for Anna. Allodynia, is that central or peripheral?
It's considered part of central sensitization. It's the clinical manifestation of central sensitization. And this is not just in migraine, but in all chronic pain conditions. Allodynia is considered as the manifestation of the central sensitization.
Wonderful. Thank you very much, all the speakers. And I thoroughly enjoyed it. And you've answered some of my questions that I wanted to ask for a long time.
So can I ask, so I'm really sorry to break it there. Can I just take a moment to ask one question to Anna and Phil?
Of course.
I'm very tempted to.
Okay, go ahead.
So Anna and Phil, I alluded to this too. I mean, if we believe vasodilatation is the initial phenomena, like some of our colleagues are suggesting, particularly those who are doing a lot of studies with provoking studies in migraine, then do you agree with me that if we believe that, then the initial, obviously, stimulation of the peripheral trigeminal system is happening due to vasodilatation? But then how do you, the clinical finding in patients is that you get premonitory symptoms before pain starts. So how do you explain that? So one has to then speculate that the peripheral trigeminal nerve system is then centrally activating very different areas of the brain, causing the mood change, the craving, and all of that before it starts pain. To me, it doesn't sound possible. Do you agree with that?
Yes, I mean, it's by far more complicated than that. I don't think there is a direct line going from vascular to trigeminal, from trigeminal to hypothalamic, and then from hypothalamic back to trigeminal. I think it's more complicated than that. And I think it has to do a lot with the secondary signaling pathways that are activated both peripherally and centrally. And for example, in your slides, you did show the cyclic AMP, which is a very important secondary signaling molecule that I think we haven't looked at in detail in migraine, and it does deserve to be looked at further, given that it is increased in all of these evoked studies, essentially of migraine, vascular or not. Essentially what they do is that they do interfere with the signaling pathway of cyclic AMP. And then if you look at most of the effective treatments in migraine, essentially one of the secondary pathways they interfere with is the cyclic AMP pathway. So, and another thing to consider is that when we're talking about targeting or the involvement of secondary molecules in migraine, is that signaling pathways in migraine is that it does take some time before we actually see the effect. It's not like a direct neurotransmitter that will excite or block the activity. It does take some time for that activity to take an effect. So as I said, it's by far more complicated, and there is a lot of work we have to do in this.
Yeah, I think my comment would be the same. I think too often in migraine, we look at one thing or the other, peripheral or central, blood vessels or nerves. And I think even at the level when you're doing lecturing and you're teaching sort of your undergraduate students, the nerves don't live in isolation. They live in an environment in which the blood vessels provide the energy and the nutrients and the things that the brain needs to function. So I think it's very difficult to dissect these two and specifically say it's one or the other. I personally believe, as my talk alluded to, that it's a central brain mechanism and we get some related vascular functional disorder there, but that's my view, of course, and I wouldn't obviously go too far against the Danish group because they're a wonderful headache centre, as you know, and really experts in their field.
Of course. Can I just one more thing? Sorry, Fayaz. How about Phil and how about if I propose that migraine pain is an illusion of pain? It is illusion of pain. It's created by the brain essentially without a peripheral input.
So I think it's clear that can happen. It's clear that you can get, because allodynia is just that. It's the perception of pain from what is a non-noxious stimuli. It's the same with photophobia. It's the perception of either a sort of painful or aversive stimuli from light that is no brighter than the person sitting next to you, but you're misappropriating that sensory stimuli. So certainly it's possible. It does happen, and we do get this misappropriation of pain. But as Anna, I think, alluded to a little earlier, where we have that peripheral arm that's feeding into that circuit, that peripheral arm will always have a role in migraine because some of that sensory information is coming from the periphery, which has then been misprocessed centrally.
Yeah, so I wouldn't say it's an illusion of the brain. I will say that it's activation of the central pain pathway, a sustained activation of the central pain pathway. That is the same pathway that will be activated if there is a peripheral nociceptive input.
Okay, guys, I think we had a very good discussion. So thanks, guys, for sparing your time to do the BASH educational webinar. And
thank you, Fayaz. Thank you so much.
And thanks to all the people who attended till the very end. Don't forget to register for the next webinar on the 28th of April, and we would have the clinical talks, pure clinical talks on acute and preventive treatment. So have a good evening, all of you. Thank you very much for joining us.
Thank you, everyone, for listening.
Thank you. Bye-bye, everyone.
Bye. Thank you.